Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back to the Rural American Surgeon Podcast. I'm your host, Dr. Randy Lehman. I have with me today a very special guest coming live from Sweden, Dr. Adrian Sava. Welcome.
Thank you, Randy.
Now, you're actually in Sweden today, right?
Of course, I am.
And it was a surgery work day for you?
Yeah, it was a normal surgery day. When you called me last time, the first and the last time, I was in Norway. So,
and you practice both in Norway and Sweden?
Yeah, you need authorization to practice in both countries. But yeah.
So let's start with an introduction of you and your training. I think our listener will find it interesting to hear maybe even the differences in training. And then we'll talk about what your practice looks like now and go from there. So tell me first about your background.
Well, if I think a little better, next year I'm going to fill 30 years in surgery. So in 1996, I started my residency in general surgery at the University Clinic here. And in 5 years, I became specialist at the same clinic. It was general surgery, mostly oncologic general surgery. Mixed upper GI and colorectal surgery. Mm-hmm. And then I think it was 2005, I was thinking about to expand my horizons. And 2006, I went twice to a fellowship in Brussels, Belgium, where I had the pleasure to meet two great professors in bariatric surgery, Guy Benacadier and Jacques Himpens at Saint-Pierre Hospital in Brussels. It was a kind of revelation for me. So I decided that I would like to continue with bariatrics. I started after, it was 2010, right after I did my PhD. So I did a lot of procedures, bariatric procedures. It was a tough time in the beginning. Here in Sweden, we used to do only gastric bypasses and Roux-en-Y gastric bypasses. But before that time, we had a lot of bariatric procedures, non-conventional bariatric procedures. In the late 80s, early 90s, here in south of Sweden, there were some surgeons that used to do vertical banded gastroplasty, VBGs. And in the early 2000s, we started with bariatrics here. So not so much experience from our side, and we started with these Roux-en-Y gastric bypasses. Mm-hmm. Maybe it's worth to mention that before us, there were some surgeons that used to do these retrocolic, retrogastric gastric bypasses. Mm-hmm. So 2006 or 2007, we started with anticolic, antigastric gastric bypasses. And then 2011, we started with gastric sleeves. Mm-hmm. It was not so many surgeons that were willing to do gastric sleeves. The concept was gastric sleeve is not that good as gastric bypass. So we did a lot of gastric bypasses here, and then 2015 I took over as a head surgeon for the entire bariatric clinic for the southern part of Sweden. So 2015, I started with most revisional surgery here. Maybe estimation, it was more than 30% revisional surgeries. Revision surgery procedures here, mostly gastric bypasses and gastric sleeves, and then a lot of revisional surgery, mostly complications after gastric bypass, revisional surgery after BBGs, and then a lot of procedures that were done in the Middle East. Our patients that used to travel there and then come back with complications. So all that gastric plications, failed sleeves, I remember it was tough time. And then 2020, I quit the public sector and started my private clinic here in southern part of Sweden, Malmö. I'm dealing right now mostly with endoscopies here in my private clinic, because it pays well, and then I'm traveling to Norway to operate as a general surgeon. And there in Norway, in two places I've been so far. One of them is a bigger clinic, a bigger hospital, regional hospital. We did a lot of laparoscopic procedures and bariatrics, of course. And the other one is a smaller hospital that we can call it rural surgery.
Okay.
Right there. Right? Yeah. So laparoscopic hernia surgery, hemorrhoids, varices. What else?
Gallstones, stuff.
Yeah, of course. Gallstones.
As an afterthought.
Yeah.
Great. A lot of stuff to dive into and unpack. First question, in the United States, training-wise, we do, if you want to become a general surgeon, or let's say bariatric surgeon, okay, you would do 4 years of college, 4 years of medical school, 5 years of general surgery residency, and then you would do a 1-year bariatric fellowship. And so after 14 years, then you would be done, then you would be a bariatric surgeon. How does that differ from like even the undergrad and medical school portions for you?
We have medical school here in Sweden, 4.5 years, and then it's just called AT, återtjänst, when you have to do your surgery rotation, internal medicine rotation, and then GP rotation. And then after 6 years, you have a medical degree. Okay.
You would go straight into that from like equivalent of high school? Like, would you be 18 when you go into that?
Right after the high school, you have to be admitted to the medical school.
Okay.
You have to be very, very good to be admitted here, like everywhere. So when you have a medical degree, then you have to look after place to do your residency. And then when you are admitted to a certain hospital, then you are doing 5 years of residency regarding general surgery. So 5 years general surgery residency here. And then you become specialist here. And after 5 years, you can be so-called consultant or attending, as you call it in the United States. So attending surgeon after 10 years of when you start your residency. So after 5 years of residency and 5 years of specialist training, and then you can choose your subspecialization. I was lucky enough to be able to choose bariatric surgery. Back in time, there were not so many places to benefit of that kind of training. So after 1 year, I became so-called bariatric surgeon here. But here in Sweden, if you are not in the hospital, at the university hospital, then the small hospitals, then you are not allowed here to, because of this political decision to centralize big surgery procedures, like upper GI surgery is centralized at the university centers. I mean, esophagus and stomach surgery, cancer surgery. I mean, and of course, hepatobiliary pancreatic surgery. Of course, this has to be at the university center. We have 1, 2, 3, 4, 5 6 university centers here, and the others are not allowed to do these kind of procedures, small hospitals. So if you have esophagus cancer, you have to send it to the university hospital, to the university clinic here. Colorectal surgery is possible to proceed here, to do here in smaller hospitals, but not in so-called rural clinics.
Yeah.
So
how about rectal cancer, APRs and stuff?
No rectal cancer here at the small hospitals, small clinics. Maybe hemicolectomies, but no rectal cancer.
Yeah, makes sense.
So I think it's almost the same as in the United States.
It is. The thing is, the United States is so huge.
Yeah.
So you've got, like, I'm looking up here, the demographics. Sweden's 10.5 million people. Yeah. And Indiana, my state, which is a smaller state, is 7 million people. So actually probably similar demographics. We've got a couple majors, like a main city, Indianapolis in the center. And then we've got a few other larger cities, like 3, maybe 4, that would probably be doing kind of what you're describing. And then like a lot of the other stuff goes, there's 2 big hospitals down in Indianapolis that like most of the HPB surgery, for example, in our state is done at. And then, but it's not like that's a hard and fast rule. It kind of depends on the doctor. So like in Lafayette, for example, there's, it kind of changes, but there's about 9 surgeons down there. And that's kind of a city with 250,000 people. And one of them will do like rectal cancer. All the rest of them don't, but they don't like not let him, and he still probably picks and chooses would be my guess. And then me, being in rural surgery, I mean, I do more things in the rural place than I would say a lot of people that are practicing in the same, well, we have what's called a critical access hospital. It has to be a hospital with 25 beds or less. A lot of times they have 2 ORs, maybe 1 endoscopy room. That's like a common size. Those are the hospitals that I'm choosing to operate in. One of them is the hospital I was born in, and I'm trying to like keep these small hospitals alive. They're a big landmark and a big figure in a small town that may only have like 5 to 10,000 people in it. And it's actually a big employer for the town. We have a lot of impoverished people, a lot of old people that live in these environments. And so the burden of travel for them is quite inconvenient, and they want their care local. So if you can go, my whole mission is go get the best training I can, bring it back close to home for these folks. And so I would say how I do my practice, there's a lot of surgeons like me in the United States, but there's also a lot of surgeons that are doing rural practice in the United States, and they're kind of just doing the scopes, and just a few minor lumps and bumps, and then taking their cases back to a city of 100 or 200,000. So both models are kind of existing in the U.S., but probably just the latter one is what's mostly happening in Sweden.
Well, it's difficult to compare Sweden with the United States with Indiana. I mean, I can say there are 2 different worlds. Well, and there are many similarities. It's the same surgery.
Right. Same surgery at the end of the day. It's just how do you kind of deliver it? We have, and then our system is very fragmented too. So do you guys have one payer? I mean, you're saying that you have your own private clinic. So I'd like to know how that works too.
Well, it depends. If your small procedures can be done at the private clinics, but not the big procedures. there are private clinics used to operate prostate cancer, and but not so far that I know, no clinic that used to operate colorectal surgery, cancer surgery. I mean, or Whipple's. No.
But what you're describing as a clinic, some places they'll have like a laparoscopic setup and they could do a gallbladder, you think?
Here in Sweden, we used to do only laparoscopic gallbladders.
Sure.
Only if it's complicated, you have to convert. But yeah, it's only laparoscopic setups.
Right, but like that would be done in a clinic, like what you're calling a clinic setting, right?
Gallbladders can be operated in both private and public hospitals.
Like for us, we would probably call it like an ambulatory surgery center, a private ambulatory surgery center. Sure. But we like clinic specifically to us usually means like just the office, you know, where we're seeing patients and maybe doing very minor things like biopsies and stuff, not like an actual procedure room or operating room. But I've talked to, just because I've talked to my cousin who lives in Germany, he told, you know, I told him I started a business called Liberty Clinic, and he's like, oh, you have your own clinic? Like it was a big deal. I'm like, no, it's just an office, you know, it's not like an OR. But now, so our audience is clear. When you're saying in the clinic, private clinic, that means probably something up to including what we'd imagine as a surgery center. Yeah. And then who's the payer? Do they have insurance that pays, or is this paid cash?
Here in Sweden, nobody's paying cash here. We have public insurance, no private insurance. We have private insurance, of course, but the public insurance is covering everything here in Sweden. So you as a patient have to pay only maybe $20 a day as long those days you are staying in. So all the rest is paid by your public insurance, health insurance.
So if you bring a person in for endoscopy in your private clinic, then the government's paying you?
You as a private clinic, you have two choices: to make a contract with a region. We are called, as you call in the United States, your states, Indiana and everything else, California or Florida. Here we are calling those states regions. And I live and work here in the southern part of Sweden, which is called Skåne, or Skåne, as you used to pronounce outside Sweden. So you have two choices: to make a contract with your region, and the region is paying for your patients. So your patients don't need to pay anything. The same at a public hospital. So they're coming in, they're paying $20, and then everything else is already paid. I can give you an example for colonoscopy. They used to pay about how much? $600. The region is paying.
Now those are US dollars or?
Yeah, US.
Okay.
Yeah. Or 6,000 Swedish crowns.
Okay.
This is what you get for one colonoscopy, plus minus $100 if you're doing polypectomy, or maybe $80 now. So these are the tariffs.
Okay.
So the patient doesn't feel a difference if they are coming to you or to the public hospitals. The politics here is to help the public hospitals, public clinics too, because they have to wait here a lot to come to.
Can you accept that payment and cover your overhead well and make a good income off of that rate?
Yeah.
Okay.
Yeah, it's all right. I don't complain.
How many scopes can you do a day?
Well, it depends. I used to do around 7-8 colonoscopies, and up to 12 until 1 o'clock, from 7 to 1. So 12 procedures, 12 endoscopies, up to 8 colonoscopies.
Okay.
5 for gastroscopies.
And then would you say your overhead's, what is it, about 50% of the total collections?
Sorry.
When I say overhead, I mean your expenses.
Well, maybe more.
More than 50% of it goes to expenses?
Have you said 50%? No. Less than 50.
Okay. So more than 15 and less than 50.
More than 30 and less than 50.
That's a big range. Yeah. Okay. I would say private practices in the United States, if they can keep their overhead below 50%, they're doing okay.
There's a lot of things you have to deal with here if you have your own private clinic. So you have to fix everything. You have to choose your own stuff, your own personnel, and you have to choose them well, very well. Otherwise, it's going to be very difficult for you.
Yeah. How many people work for you?
4.
Any of them family members?
No.
Okay. And no other doctors in the practice?
I'm the only one.
Okay. Gotcha. So what do you need? Like a surgery tech and a nurse maybe? Or who all? What's your staff look like?
2 nurses and 3 and 1...
like office person?
Office secretary.
Yeah. Okay. Very good. Well, that's a great intro, and I just think it's so, like you said, different and foreign to what we basically do. Although, here you have that opportunity to take Medicare, make your own practice if you want to, but most people choose to work for hospitals the way that it's going right now. And then there's actually surgery center. I think the other second option you were going to say is don't contract with the government. Would it just be cash pay, or would be commercial insurance that would be paying in that second option?
If you choose not to make a contract with the region or the government,
right.
Here in Sweden, you are already handicapped as a private doctor, because most of the patients are going to choose the option not to pay, because here in our country, everyone is already paying their health insurance.
Yeah.
So why pay more when I can pay less?
Right. Of course. Yeah. But in the United States, we actually have a couple places that are starting up. It's a newer concept, which are cutting out insurance altogether, cutting out the government altogether. And they have basically a cash price. The people love the transparency, right? And they love the service. And, no wait lines, and usually the service is better. And there was a place in Oklahoma that started it. And now in Indiana, we have Wellbridge Surgical. I think it's in just north side of Indianapolis. And it's a cash only surgery center. And we have people in the United States that have very high deductible plans. And those people will use those services. And so will, there's like Christian health sharing ministries, where it's like having insurance, but they're still cost sensitive because they're actually turning it into the group. And so those places will seek out, those people will usually seek out the lowest cost. Some people still don't have insurance, although they should be able to get government insurance if they want to. And then now we're having people like from Canada, where there's like a long wait line up there, and they're like, I'll just pay. So you can get my gallbladder out for $6,500. All right. I'll just come down and do it, So I'm very curious to see how that goes, because generally I'm definitely a capitalist, and I believe in a free market. And I'm living it and breathing every day the waste in healthcare that predominantly in the United States predominantly occurs because we have to have an army of people on our billing end to fight with the army of people that are working on the insurance side. And the people that have been hired by insurance they exist to deny claims, and they've been told, they're instructed to deny. And we have to have a people basically to fight that. They just blanket deny like 10% right off the top, and they'll just choose not to respond for no reason and not pay you, and you have to go chase it down. And it's only because they're trying to make it hard enough that you eventually say, forget it, I'm going to consider that bad debt and not have to get paid. That's the problem with the for-profit insurance companies.
Well, if you live in a country that you can choose how you're going to pay your taxes, I think it's all right. But if you live here, it's impossible to choose your how you're going to pay your taxes, because the state is already taking your taxes between 40 and 60%. So if you are already paying the taxes, how can you choose to pay extra,
right,
for a private care provider?
Yep.
So this is the biggest difference here. We are all paying here, so why should I pay more?
Yeah.
But if you, I don't like politics and economics, but sometimes you have to say it bluntly. It covers a lot. You don't have to pay for your studies. You have no loans here. My kids, they're grown-ups, didn't have to pay anything for their medical degrees.
Mm-hmm.
So there are pros and cons. So
yep. I think it's just different, and you're absolutely right. That's not like right or wrong. It's just very different. Of course, obviously, I greatly prefer like what I grew up with.
I totally agree and understand your point.
That's why freedom is one of my greatest values. It's probably because it's been preached to me because I grew up in America. But let's move on though to some other sections of the show. First one is just, why is surgery special to you? So what is it about your job that you said you're fortunate to get into? You use words like that, and you seem like you are proud of what you've been able to do. And why is that? What's so special about this job?
In my case, surgery was a call. In the early 80s, as a teenager, I already knew deep in my heart, that I'm going to pursue a medical career. So 1990, I got admitted to medical school. And then 2 years before in the fourth year of medical school, I went to my university professor and told him, I want to be a surgeon. What should I do in order to become a surgeon? And he told me, you know what? Go to the ER and learn some things, and then he came and controlled it checked me up and if I was there. So in my final year, I went to him. I went back to him and I told him, you know what? I heard what he said to me. I went to the UR and I was there for 2 years in my free time, and I would like to continue to be a surgeon to fulfill my dream. And then he said, okay, you can be my resident. And I started to help one of the best professors in general surgery I have ever seen in my life. I was blessed in my life. I can admit it. So for me, it was very simple, straightforward, a call. But it came with a lot of sacrifices. You have to sacrifice something in your life: your free time, your time with your kids, your children. And then when they are 18, they're going to tell you, as my son told me, you know, Dad, you were never home when I was a kid. So that's why I'm not going to be a doctor. So he became a dentist. It's my daughter.
And your daughter as well, right?
My daughter as well. So
yeah.
Both myself and my wife, we are both doctors. My wife is an ophthalmologist. So
okay,
it's not easy to have two parents, doctors.
Yeah.
So there is sacrifice in everything you do.
Anything that you would do different?
If I had to choose, if I can choose now,
right?
in 1996. Maybe not general surgery, maybe plastic surgery. Because I like plastic surgery, and I was always have been attracted to plastic surgery. So when I became specialist in general surgery, I applied to plastic surgery too.
Okay.
And then for some reasons I said no. I should continue with general surgery.
Sure.
Plastic surgery was my second call.
Is plastic surgery like, are you talking mostly cosmetic surgery, or is it like reconstructive functional surgery that interests you the most? Okay.
Mostly reconstructive surgery.
Very interesting. So now that you did go the path that you went, you landed on basically being a bariatric surgery. We usually do a how I do it section of the show. And today we're going to talk about Roux-en-Y gastric bypass. We will talk about the operation itself, but also just some differences from the U.S. So we usually start with indications. Obviously, obesity is your Roux-en-Y gastric bypass. Obviously, there's certain things like a sleeve. You're not, if you have a patient with reflux disease, you're not going to do a sleeve. You choose a Roux-en-Y gastric bypass. Is there anything besides that reflux component that would make you choose a Roux-en-Y gastric bypass over some other bariatric operation?
Before 2015, Roux-en-Y gastric bypass was number one here in Sweden. And then we started to make more sleeves than gastric bypasses here for some reason. But
just because it's easier, probably, right?
And no, because it's easier. Because it depends. If you have a patient that is high obese, that has a BMI, let's say 55, it's not easy to choose a sleeve. I'm going always to recommend a gastric bypass. But if you have if you have a patient with BMI 40, 41, no reflux, young patient, never been pregnant before, why not a sleeve? So it depends. If you have a diabetic, which is difficult to control, then a gastric bypass it could be the best option. But you have to think about a possible complication after a gastric bypass. So gastric bypass is not a complication-free. You have to do it properly. But even if you do it perfectly, there are complications that can occur. So it's a difficult choice. Sometimes you start an operation thinking about, okay, we are going to do a sleeve. And then when you start to free around G junction, and you can see that this patient has hiatal hernia, and then maybe it's better to do a bypass.
And there's room to switch, like you kind of go to the operating room sort of consented for both.
Yeah, you have to you need a concession. The patient has to give you a concession. So if you used to ask the patient before, do I have free hands to choose myself, which is better for you? And if the patient says, no, I will only have a gastric sleeve, okay, then we're doing sleeve. Except if there's a big hiatal hernia, then you have to tell the patient, okay, if you have a big hiatal hernia, we don't use to do preoperative CT scans on every patient. So sometimes we don't know on a regular basis if the patient has no symptoms. Then we don't use to do a gastroscopy before sleeve or bypass.
Okay.
Neither. So sometimes there's a intraoperative surprise that you have over 3 centimeters hiatal hernia. Then you have to do to suture the hiatus and do the sleeve. But hiatus sutures sometimes can fail. and then you have a sleeve herniation, and then it's much worse than before. Then you have to do to convert the sleeve to gastric bypass because of the reflux. Regarding gastric bypass, there are a lot of things to consider when you choose a gastric bypass. For 5 years ago, we started to do single anastomosis sleeve ileal bypass. It's a combination between sleeve and gastric bypass. You do a sleeve, and then you go to the ileocecal valve, and then measure 120 centimeters, and then do a gastro-enteral anastomosis. So single anastomosis sleeve ileal, SASI, S-A-S-I. We don't do here in Sweden. So far, I know. As far as I know, we don't do SASIs. SADS. We stopped doing dual switches. Not anymore.
And then when you do your sleeve, your SASI, you divide. Is it pre or post pyloric to make your anastomosis? Because you do your sleeve, and then you divide somewhere between the stomach and the duo, right?
You don't divide anything. You do a sleeve, and then 120 centimeters distal from proximal from ileocecal valve. You're lifting up small bowel and do a gastroenteral anastomosis. Gastroenteral.
So you leave the last part of the stomach and the pylorus all attached to the.
Sure.
Okay.
You try to do as close as possible to the pylorus in the antrum part.
Got it.
The anastomosis.
And they're still actively doing that? Which patient would that operation be best for?
For what?
For a SASI, SASI.
SASI. The ones who want to have a sleeve.
Okay.
But is bigger than usual.
Okay. So high BMI.
High BMI or refuses to have a gastric bypass.
But refuses to have a gastric bypass. And they can't have reflux.
Yeah, sure. Every sleeve has to come without reflux. So no sleeve with a reflux.
Okay.
With GERD.
Got it. Well, let's talk about your technique for the Roux-en-Y gastric bypass. First question, are you doing everything straight stick laparoscopic, or are you using the robot?
Not here. Not in our center, we don't use robotic bariatric surgery because the costs are too high for a simple procedure. So for us, it takes 40 minutes to do a gastric bypass, 20 minutes to do a sleeve. So it doesn't justify the costs. If you do robotic surgery is much easier, of course.
Sure.
You have to train. Learning curvature for laparoscopic surgery is much longer than for robotic surgery. So no, I'm just using laparoscopic surgery.
Okay.
So procedure is simple. Yeah.
Talk me through we'll just choose Roux-en-Y because we have to pick one. We can't talk about every case, but talk me through how you do the operation from positioning, port placement, how you do, every step of it.
The patient is in a beach chair position. You're standing between the legs. You as an operator and your assistant is on the patient's left side. So only one assistant. And the assisting nurse is on the patient's right side. So, normal port positioning. You're coming in the lesser sac right below the G junction, and then you are stapling horizontally with a 45 linear stapler. We are using the Covidian's yellow cartridge. And then one or maybe two vertical cartridges too. So the the goal is to have a very small pouch, only in order to be able to make a gastroenteral anastomosis. Not more, maximum 3-4 centimeters, 3 by 3 or 4 by 3 centimeters. So very small pouch. This is the goal. And then you're switching to the infracolic region. You're lifting up your transverse colon, identify the trite ligament, and then measuring around 60 centimeters. And this is the BP limb. And you lift, you make a small incision, and with a linear stapler 45 millimeter, the same yellow magazine, you're stapling with a small pouch. And then 120 in roux limb, and then you're doing enter anastomosis with the same 45 cartridge. Yellow cartridge convenience, and then you're closing the hose, of course, with the G or NE anastomosis or JJ anastomosis. And then when you're done with it, you have to close the defect, the mesenteric defect. We are still using. We have these metallic clips that help us to close the defects very fast.
Let me pause you for 1 second and just ask a specific question about how you did your JJ laparoscopically. So you're bringing your, obviously, 60 centimeters distal to ligament of trites, 120 centimeter roux limb. You line them up side by side, and do you place a stitch or anything to hold it before you make your interotomies and slide your stapler in?
No, when the assistant is holding the BP limb, and me as a operator, I'm holding the roux limb.
Yep.
With sun incision, I make one hole in the BP limb, one hole in the roux limb, and then in with a stapler. Stapling, and then the remnant, the whole I'm suturing with resolvable micro suture.
2 layers or 1 layer?
V-lock. 2 layers in the GE and 1 layer in JJ anastomosis.
Just a 1 layer, and then are you your first when you put that when you stitch that down? Anything special? Like, is that a canal stitch or anything? Like, is
I'm holding with a needle holder like this. Mm-hmm. Then I'm sewing just regular suture in G anastomosis.
Over
2 layers.
And over, not in out on the other side. Yeah. You're just doing over and over.
And and then JJ anastomosis only 1 layer.
Yeah.
We are still using Vicryl, but
3.0 Vicryl.
Yeah, 3.0.
Your knots, they're outside of the bowel? You're not burying a knot, right?
Always outside the bowel. And then leakage test with 32 French tube through the G anastomosis. It's mandatory.
Okay.
A leakage test.
Obviously, don't do that for the JJ.
No. Yeah. Not for the JJ. But there are some finesse when you're doing the JJ. You have to be very careful when you suture the JJ anastomosis, the hole after stapling, in order to not to be very hard when you do the suture, because you don't need this JJ kinking. This is very important in order to avoid this chronic abdominal pain, because the chronic abdominal pain is almost always related to the dysfunctional JJ anastomosis. And when you close the mesenteric defect to the JJ anastomosis, you have to be very careful not to do very hard, to take too much tissue.
Yeah.
Because you have to avoid this kinking.
The reason I dive
of
so
course,
deep into this is because I'll have a lot of well, first off, myself, and my audience is basically somebody like myself, like a general surgeon, non-bariatric. And if you want to do a laparoscopic small bowel to small bowel anastomosis, that's very much a general surgery operation. Say you're operating for bowel obstruction and you're trying to keep your incisions small and whatnot. So that's why I'm digging in really deep to exactly the technique of this and looking for your tips. So.
Well, another tip is to divide in the mesentery before your stapling, in order to have a free JJ anastomosis. Otherwise, you're going to have a very high JJ anastomosis, which is prone to this kinking lately, and then it can cause this chronic abdominal pain, post-gastric bypass. Nobody can explain what is going on. Nothing on the you cannot see anything on CT scans. This is very difficult.
Okay.
To solve.
So when I understand you're bringing the it's basically isoperistaltic, the two limbs.
No, it's antiperistaltic, because when you're done the JJ anastomosis, you have to divide the BP limb from. It has to fall down.
Right, but the stuff is coming down this way, and also the stuff is coming down your Roux limb this way too, right?
Because when you're done with the GE anastomosis, you're going down 120 centimeters, and then you have to do a JG anastomosis. You're sewing the hole, and then you have to divide between these two anastomoses with a stapler. And then this JG anastomosis has to fall down properly. Otherwise, it's going to be very, very difficult to fix it.
Okay.
If you follow with me.
I'm not, but that's okay. And I might take this out because I'm not so sure. Let me try to ask just practically. So you have your BP limb coming down and it's cut, right? Then you you do the JJ first, right?
No, I'm doing the GE first.
Okay, so you drag that up and you do your GJ. Now, this limb is hanging down 120 centimeters. They don't run this side by side like this. You actually come down, loop, and it comes back up alongside, like something like this.
When you're doing your first anastomosis, gastroenteral anastomosis, and then you are doing your JJ anastomosis, then you have an omega loop.
Okay.
Isn't it? And then you have to convert this omega loop into a Roux-en-Y loop. That's why you have to divide these two anastomoses.
Okay.
I'm not sure.
Okay. I don't do, not doing bariatric training like did a few cases. But
if you start, Randy, if you start from the beginning, you are starting from so you have your small pouch, gastric pouch, prepared, isn't it? And then you are identify your trite ligament. And 60 centimeters, you're lifting up.
Yes.
Anticolic,
yes,
and antigastric. This small bowel to the small pouch.
Yes.
And then you have an omega loop.
Yep.
Isn't it? And then you are doing your gastroenteral anastomosis. And then you are doing your JJ anastomosis. But then you have to divide between these two anastomoses in order to have a separation to convert your omega loop into a Roux-en-Y loop. This is the Swedish technique, we used to call it. But everyone else is doing this right now. So I have to write it down. Here we have the small pouch here. This is the small pouch. And this is the trite ligament. And this is the BP limb, 120. This is the BP limb here. This is the Roux limb, 120, 60.
Yeah.
And between this one and this one, you have to divide. Otherwise, you have a omega loop. So this is the Roux limb.
That makes sense. I'm going to draw what I was imagining, and you'll see what I was talking about. I was imagining more like this. See that?
Yeah, I can see that.
But it's not that. It's this guy here is looped back up, so they're anti.
No, in reality, it's going to be like this. It's antiperistaltic JJ anastomosis. So this one is the same intestine from this one.
Mm-hmm.
But this one is falling down.
Yeah, and you just let it slide down, and then it goes up antiperistaltic. And is there a reason for that? And what if you didn't do that? What if you flipped that upside down and it was isoperistaltic?
It's much easier to do it technically.
Okay.
Like this. Because
you're
the first
holding on the cut end, right? So she can hold your cut end of your BP limb up.
You have a hole here. You have a suture here. Yeah. You're coming in here with your staple. And then you're stapling here and then suturing here and then dividing between this one and this one.
Yep. Okay. Thank you for bearing with me. For me, being the podcast host, sometimes I have to make myself vulnerable and expose my ignorance so that I can help other people, because I'm sure if I'm struggling with it, somebody else probably that was helpful for them too. So that makes sense. I think we're good on talking about do you hand sew that GJ or do you staple that?
Gastroenteroanastomosis, you mean?
Yeah. Well, I'm sorry. I say GJ because gastrojejunal anastomosis.
Gastrojejunal, yeah. Okay, yeah. Of course. I am always stapling. When I learned myself bariatric surgery, I remember that Professor Cadier had three patients that day. So he asked us, which one would you like to see as first? So we said, circular staple. Okay, let's do a circular stapling. And GJ anastomosis. And then the next one, linear staple. Okay, let's do it linear. And the third one was a hand suture. So he did a hand suture, GJ anastomosis. So we are not doing basically. We are not doing anymore. It was a long time ago. We stopped using a circular staple.
Yeah, because you have to make another hole, right?
Yeah, of course. So this is not practical anymore for us. But if you're very good, you can do a totally hand sutured GJ anastomosis. But this is not better, and otherwise, linear staple GJ anastomosis is much faster, and all you have to do is to close the hole. Mm-hmm. So. But you have to be very careful when you staple the GJ anastomosis with your 45 magazine. You have to rotate a little bit before you close the magazine, in order to avoid on the back side there is a small part of a gastric pouch that used to became ischemic. So this is the most frequent cause of ulcer in GJ anastomosis, ischemia. So very, very, very careful if you are doing the stapling. If you close a staple, you have to rotate a little bit in order to have a bigger area on the back side that is not going to be ischemic. That can cause a marginal ulcer. Yep. So. We all know that those they are smoking, those they are drinking or using NSA. These they are causing. They have a complication as a marginal ulcer, right? Marginal ulcer, but the anatomopathological cause is ischemia. So. Less ischemia, less marginal ulcers.
Yeah, I guess that makes sense. I mean, I guess maybe not on the inside bit, but yeah, you can always heal those problems if you have better blood flow. Yeah. Makes sense. Hey, I got one more question before we switch to the next segment of the show. But what do you think about the smart tissue autonomous robot and supposedly robot suturing a bowel anastomosis better than a human? Have you heard that?
Better than a human?
autonomous robot. I'm not talking about human guided robot.
I understand. Yeah. I have no experience with it. For me, robotic surgery is something special. It's much easier to perform, especially when you are operating ventral hernias. It's much easier to work in the roof. So you have more freedom to do the sutures the way you want. But I have no experience with autonomous robots. It's difficult to say if they can totally replace humans. I don't know. Maybe.
Yeah, I agree. It's crazy, but that's what they had. Robot completely, like, it's like the human. Okay, sets up the robot to do the most critical part of the operation. Sounds a bit crazy, but maybe something.
Maybe. I think my personal belief is that robots are going to replace many professions, but the surgeons are going to be the last ones.
Mm-hmm. Yeah, tend to agree. Very good. Let's keep moving. So we have to get on to the other parts of the show, which next would be the financial corner. I was wondering if you had a money tip for our listener.
Surgery is difficult. It's not easy. It's taking its toll on your family. Don't get divorced, for sure. But you need a partner to understand you, to support you.
Sure. Yeah.
Because you as a surgeon have ups and downs, and there are days that can be very difficult.
Are things harder for you in your practice after training or during training? And I guess I'll say harder on your relationship with your spouse.
The hardest was in the beginning when I was a resident.
Yeah.
As my son used to say, I were never home.
Yeah.
So it's difficult. It's not easy.
So I had a mentor that told me, we got married the first year of residency, 5 years. And we got married the first year. And he said, if you can make it through residency, you can make it through anything. And I do feel that way. Like after I got out of residency, I felt like I had a lot more control over my time and my practice, and I could ramp things up and down, and meet. I've definitely there a lot more for my family. I'm with my family a ton, and the flexibility, I'm very intentional about it too. I don't have that many other hobbies outside of work and family, but now's the time because I have a 6-year-old and an 8-year-old, and I don't want them. I know people on both sides of the spectrum, people that their kids are doing exactly what they did, which tells you that their kid believes that it's a good life. And then others, a lot of people I know that their kids say kind of what your kids are saying, which is, I'm choosing not to do that because of what I saw, the toll it took on you. I'm not trying to get my kids to just do what I did, but I don't want them to be able to say, I'm not doing it because of this, the impact on the family. Yeah.
In order to survive as a surgeon, you need to have a discipline. This is what I told to my kids. You have to sleep when you have time, because you never know what is coming next, the next hour or the next hours. So you have to eat when you can. You cannot afford to do this intermittent fasting. It's difficult as a surgery resident. But then when you're done with your residency, you have more time for your family. You have more time for your spouse. It's true. And your financial situation is much better, of course.
Yeah.
But what remains is your discipline. I have to admit one thing. You live almost as a soldier.
Yeah, there's an element of that. And definitely that eat when you can, sleep when you can, don't mess with the pancreas is...
Of course.
Sounds like it's an international...
This is not actual anymore.
Mantra. Yeah, but now not anymore. That's correct. Very good. Well, we usually do classic rural surgery stories, but now we'll just do classic surgery story. Do you have anything that is just classic surgery that you've told a couple times in the surgery lounge because you just hardly can't believe it yourself? I'm sure you have plenty.
There are some stories, but my personal experience. I used to train residents before, and maybe this is not actual anymore, but my mentors insisted that you have to do this clinical exam before, and then ask for lab and CT scans and everything. Because I remember when I was in my first years as a resident, I called my attending colleague to take a look on a patient. And then he told me from the door, I can tell you the diagnosis. And I said, why don't you just do the palpation and everything else? This patient has abdominal asymmetry. What can it be? Well, as a resident in the first year, I said, I don't know, a lot of things. No, he said, only one thing, sigmoidium volvulus. And it wasn't that.
Whoa. I need to diagnose
abdominal asymmetry. And then, in the OR, sometimes it feels like you're desperate. And I remember one of my first esophageal resections. I had a very bad. I shouldn't allow to say it, but my assistant was not that good.
Yeah, sure.
And then I felt like this. I'm desperate. I have no help. What should I do? I got some supradiaphragmatic bleeding, and I started to panic. Mm-hmm. And the anesthesiologist was my friend. He's older than I am. And he told me then, Adrian, calm down. You can fix it. If you're lost, then we are all lost. So at the end of the day, you as a surgeon, as a operative surgeon, not an assistant surgeon, you have to think like this. You have to fix it. And it's you, not someone else. And then this is what helped me when I became an attendant, and I had a resident that helped me with a obese patient that had fishbone into the pancreas.
Oh.
And I started to dissect. I started laparoscopically, and I came into the lesser sac. Nothing there. And of course, I had to convert to open, a big guy, over 15 BMI. And then nothing there, nothing in the lesser sac. I couldn't find anything. And then I said, could you all please be quiet in the operation room? And I took a long peon dissector, and then just relied on my feelings. And then I heard it like on the bone. It was a perpendicular fish bone that has perforated the backside of the duodenum into the pancreas. We are calling it Seborg. No Röntgen, imagistic, no nothing. Only relying on a feeling. Yeah. And then close your peon clamp and then take it out. Such a big bone.
Big fish bone. Wow. That's a good one too.
We have a lot of stories, but the worst is to discover that you did it wrong. You injured something. It happened to me once. I injured a CBD, not knowing, and then you have to reconstruct by yourself. You have to learn to reconstruct, to fix your own errors. This is the most tricky part of our of the surgery, to fix your own mistakes.
Yeah. So here, actually in the U.S., in rural surgery, this kind of is a hot topic, the CBD injury. Identified intraoperatively, I would say increasingly more and more we're encouraged not to fix it ourselves and to ship to an HPB surgeon. And the HPB people are specifically asking us to do that. Is that, I would say, true, say, in those small community settings with no HPB training in Sweden?
It wasn't that difficult for me because I could do it by myself. But here in Sweden, after 2010, it's mandatory for every cholecystectomy to do an intraoperative cholangiography on the table.
Okay.
So when you dissect and before you divide the cystic duct, you have to make a small hole inside with a.
I do that routinely, but I would say I'm in a minority. I would say there's probably 15% of people in the U.S. that do that routinely. I do it mostly because I'm in a small hospital and we don't do that many. And I want them, when I want to be able to do it, when I have to, I want it to be able to be easy. So I just do it for everyone. That way it's easy. Now, even then, sometimes my catheter catches on a valve or something and I have a hard time. What if in that situation, like, are the surgeons, they have to get that full cholangiogram before they get off the table, no matter what?
No, it's not 100%. You have to do it, but if you can, it's good. It's good to do it.
Okay.
Put your catheter through the cysticus into the CBD, but if it's very high inflammation there, sometimes it's very difficult. So just divide it. You have to be sure that you're not dividing very too close to the CBD. Right. So it's better to leave some extra remnant than to instead of injure to the CBD. So right. This is difficult. There are many anatomic variants. So gallbladder surgery it can be very tricky. It can be very tricky. Sometimes.
I had a mentor tell me there's no glory in a lap chole. Because if it goes well, it's just expected to go well. But then when it goes bad, and it's all your fault. Yeah. So, all right, very good. Any resources that you use on a regular basis? The last segment of our show is resources for the busy rural surgeon, like maybe web-based or book resources that you just think are you just wouldn't live without.
As a rural surgeon, as a rural surgeon, you have to do TEPs, TAP. Inguinal hernias, small things, cholecystectomies. Keep yourself updated. Talk to the colleagues. If you're doing bariatric surgery, you have to be updated. You have to go to these IFSO congresses every year, if so, in order to hear the others how they are doing, what kind of results they have.
Are you a member of American College of Surgeons?
No.
Okay. So you have your own organizations and things. What's funny about what you said, not funny, but just like, almost expected, is that's the most common thing that most of my guests say. They say your cell phone, your contacts, and your groups and your professional organizations, those are the best resources to just stay in contact with other surgeons. I thought when I started the show and I had this segment, I was thinking, well, someone's going to give me like website stuff, textbooks that they love, things like that. But it's not. It's really that, connecting with other surgeons that I think is going to be able to power you through what you now have is like a 30-year career. Something to be proud of.
I don't have to be a member of American College of Surgery.
Right.
I am a member of Swedish College of Surgery.
Right, exactly. Yeah. But for us, I would say American College of Surgeons is a good place to be. For a rural surgeon, we actually have the North American Rural Surgical Society, which I'm a member of and a big proponent of. So yeah, there's whether you're bariatrics, your colorectal, whatever your specialty groups are, stay connected. Yeah.
At the end of the day, I still remember a colleague from Norway. He's my age. After I had to redo his colostomy, he fought very hard to do a robotic rectal resection. No, it was amputation, and then he did a colostomy, and then it was another one of the best colostomies. And so I had to. I was on call a few days after this operation, and then I had to redo this. And he was so sad. But at the end of the day, he said, "You know what, Adrian? At the end of the day, this is only a profession. To be a surgeon is only a job. At the end of the day, we have sacrificed a lot, but you don't have to have sacrificed your whole life. It's only a job. It affects you a lot. Your fails. You wish to do it perfectly, but I have another friend. He is one of the best esophageal cancer surgeon. But he's not operating anymore. He's just giving advices and everything. He used to say, in the last 5 years, I'm the only surgeon that has no complications. I raised my eyebrows and I said, how it comes? He said, I'm not operating anymore.
I stopped operating 5 years ago. Exactly.
Of course. So this is only a job at the end of the day.
Yeah, it can be hard to separate your identity. I mean, when you pour so much into it, but you have to, and you carry around the surgeon's graveyard, they call it. Basically, you're talking about your failures, your complications. But, what is the best, maybe as we close, what is the best way to maintain that sort of separation, the healthy separation from surgery as your job, if you will, and you as a person?
You need to find your own balance. It's difficult to give advice to someone, to a colleague, because your own balance can be different. It's not the same as my own balance. So you have to find your hobbies. You have to respect your family.
Yeah.
It's difficult. Sometimes the burnout syndrome is. I have many colleagues. I was almost there. This burnout syndrome can eat you up. It's difficult. Sometimes you're losing your way. You're just working, patience, and then who is suffering? Your family, yourself. You have to look after your health, your spine problems, as every surgeon.
Yeah. Tell me, lastly, I think you're a member and a leader in the Nazarene Church in Sweden. And so how does that affect you on a daily life as you talk about this balance? Maybe you think about your purpose and your why you exist. How does your faith come into play?
As a minister, you have to respect the God's word. It's not interfering in a negative way. It's interfering with your faith in a more positive way. So, but you have to be very careful to be humble. To be humble, to know your place. As a surgeon, sometimes you used to ride high.
Yeah, that's the reputation.
You have to remember yourself in the mirror. Be humble. Thank God for everything. And follow Christ.
Yeah.
It's that simple.
Yeah, that's beautiful. Surgery is a very humbling profession. Easy to get cocky in surgery. Hard to stay that way, though.
Of course.
Yeah.
And I have to thank my family for that. They are putting me down every time. we as the surgeons, we used to be cocky. That's often.
That's great. Well, this has been absolutely my pleasure. And I'm so glad the internet has worked so well across the pond. I mean, this is like, it's like you're, in the next town over. I can't believe it.
Well, one of the miracles that has to be used properly.
Yep. Yes. So thank you so much. And if you're ever out my direction, I hope you look me up and you keep doing all this great work that you're doing. And I really appreciate you being a guest on the show.
Thank you for having me. I wish you all the blessings and keep doing what you do. This is a blessing to be there where you, in your hometown, to do surgery there. Everyone knows you.
Yep, it's beautiful.
This is a big blessing.
Yep, it was everything I pretty much hoped for. And thank you also to the listener for being with us for this episode of The Rural American Surgeon, and we will see you on the next episode of the show.